Treatment of locally advanced renal cell carcinoma, surgery for tumor thrombus in the IVC. Renal tumors are unique in their ability to form this tumor thrombi, which can propagate from the ipsilateral renal vein into IVC, extend as far as the patient's right atrium. Approximately 4 to 10% of these patients who present with renal masses will have a concomitant thrombus, tumor thrombus, 4 to 10%. And the level of tumor thrombus is classified as level 0, thrombus limited to renal veins is level 0. Level 1 is thrombus extending into the inferior vena cava 2 cm less than equal to 2 cm above renal vein, that is level 1. Level 2 is thrombus extending into the IVC more than 2 cm above renal vein but below hepatic vein. Level 3 is thrombus extending into IVC above the level of the hepatic vein but still remaining below the diaphragm. And level 4 is thrombus extending into IVC above the level of the diaphragm. So this is a classification for renal tumor: anatomical, less than 2 cm above renal vein, more than 2 cm above renal vein but below the hepatic veins, and then IVC thrombus above renal vein below diaphragm, above hepatic vein below diaphragm, and IVC above diaphragm level 0, 1, 2, 3 and 4. This is anatomical landmarks. A tumor thrombus should be suspected in patients with a renal tumor who have new onset of lower extremity edema, then isolated right-sided varicocele, or does not collapse with recurrency or dilated superficial abdominal vein and proteinuria, pulmonary embolism, right atrial mass, non-visualization or contrast imaging of the involved kidney due to renal vein occlusion. And 5-year case-specific survival for patients with the RCC and venous extension ranges from 45 to 70%. Surgical therapy in the form of radical nephrectomy and IVC thrombectomy can be curative. Interestingly, many patients with vena cava extension will present without metastatic disease. Prognostic significance of IVC thrombus level has been controversial. Most studies suggest that the incidence of locoregional or systemic progression is higher in patients with level 3 to 4 IVC thrombus, which may account for the reduced survival reported in this subgroup in some series. Other series have shown that any IVC involvement is worse when renal vein involvement, without distinction with regard to IVC level. In this series, other factors such as nodal or metastatic involvement and tumor grade have more impact on overall survival. Despite this debate, patients with N0, M0 lesions and tumor thrombus level at any level may be cured with surgical resection. Clinical variables associated with the survival following surgery in patients with tumor thrombi are somewhat conflicting, giving retrospective nature of the reports. The level of tumor thrombi has been associated with the survival in some series showing improved survival with level 1 and 2 tumor thrombus compared to level 3, 4 tumor thrombi, that is 6.6 years versus 1.4 years. Others have associated tumor histological characteristics are far more important prognostic. Histological characteristics, they are far more important prognostic measure. A recent international multi-institutional retrospective study analyzed the role of tumor histology on survival in patients undergoing radical nephrectomy and caval thrombectomy. 5-year survival, overall survival is 53%, and multivariate analysis of papillary histology, fat invasion, thrombus levels, they were independent prognostic factor of poor cancer specific survival. The 3 factors: first is papillary histology, second is fat invasion, and third is tumor thrombus level. They were independent predictor of poor cancer specific survival: papillary histology, fat invasion and thrombus level. Surgery remains an integral part of treatment paradigm in patients with tumor venous extension because of the sequel of this vascular involvement. In the surgical approach and technique to treat these challenging tumors are tailored to the level of IVC thrombus level of IVC thrombus, but uniformly begin with the careful mobilization of the kidney and early ligation of the arterial blood flow. With the increasing tumor thrombus level, more advanced surgical techniques and multidisciplinary surgical teams are required for vasculature control and complete tumor extirpation, and including veno-venous bypass and cardiopulmonary bypass, potentially with hypothermic circulatory arrest for some cases. Recently, several imaging characteristics have been proposed to predict the need for complex vascular reconstruction. In a retrospective study of 172 patients with Sutka et al. Showed an right-sided tumor thrombus, AP diameter of the IVC at the renal ostium of at least 34 mm, and radiographic evidence of complete IVC occlusion were predictors of complex vascular reconstruction, and more importantly was that the absence of any of these findings, only 2% of the patients require complete complex reconstruction. Absence of any of this finding. Sutka et al. Showed right-sided tumor thrombus, AP diameter 34 mm, at least radiographic evidence of IVC, complete IVC occlusion. They were predictor of complex vascular reconstruction, and absence of any of these factors, only 2% patients required complex reconstruction. Despite the surgical ability to resect this tumor thrombi, perioperative mortality rates were associated with radical nephrectomy, and IVC thrombectomy have been reported to be perioperative mortality rate is 5 to 10%. Depending on the patient comorbidities and tumor characteristics, in an efforts to downsize the tumor thrombus and lessens the surgical morbidity, neoadjuvant treatment with targeted agents has been studied with inconsistent and disappointing results. In the largest study, which included 25 patients with level 3-4 thrombi, use of targeted agents had a minimal effect in downsizing. Targeted agents have minimal effect in downsizing the tumor thrombi in any surgically meaningful measure. Several small retrospective reports have noted significant thrombus reduction with the use of IO agent, some reporting complete thrombus regression. Stereotactic SBRT has shown promise with symptom palliation in those suffering from intractable edema, ascites, and cardiac and liver dysfunction, who all will not benefit from surgical procedure due to risk of perioperative morbidity or otherwise limited life expectancy. Thank you.